Welcome, team. Okay, picture this. You've just stepped onto the floor of the emergency department, and that triage note in your hand, it just screams chest pain.
Mm-hmm.
Forget the textbooks for a minute. Today, we are doing a focused deep dive into probably the absolute highest stakes presentation we see, the acute cardiac patient.
Yeah.
And this is, less about memorizing definitions and way more about translating that knowledge directly into action right now, under pressure.
That's the mission. That's exactly it. Our sources for this are all rooted in these comprehensive emergency medicine protocols, and they basically give us the practical scaffolding, the framework that an experienced clinician needs.
So it's a mental checklist.
It is. We want to equip you with that mental checklist you need to, execute life-saving interventions in that first hour. We're going deep on the whole spectrum of acute coronary syndromes, the subtle but deadly mimics, and then the really scary stuff, the sudden death, electrical, and vascular catastrophes.
It's all about pattern recognition.
Seeing the pattern and triggering the right protocol instantly.
Okay, so before we even get near the ECG machine, let's nail down the one foundational rule that really dictates our entire ED flow. It starts the second that patient crosses the threshold.
That principle is triage. I mean, its whole purpose is to categorize every single patient based on their medical need and, frankly, the resources we have available. It's all about ensuring the sickest patients get seen first.
And there are guidelines for this, right?
Oh, absolutely. The Royal College of Emergency Medicine, the RCEM, their guidelines are crystal clear. Your patient should not wait more than 15 minutes to be triaged. That initial assessment it's just critical.
And as our source material really emphasizes, that 15-minute clock is ticking, but triage itself, it's a dynamic process. It's not just a one-and-done snapshot.
No, not at all. A patient who seems totally stable at first can deteriorate so rapidly. And that's why these integrated scoring systems are just essential.
You mean like new WS2?
It's exactly. Systems like new WS2, the National Early Warning Score, they're incorporated right into the triage process to help us systematically identify that deterioration. The experienced triage nurse isn't just taking vitals, they're doing crucial independent actions.
Like what?
They're getting IV access, they're putting on high-flow oxygen if it's needed, and critically, they're giving immediate analgesia for pain.
So triage isn't just a waiting room, it's really the first active stage of resuscitation.
It absolutely is.
All right, let's shift our focus to the heart muscle itself. When we talk about acute coronary syndromes, or ACS, we're really talking about a group of conditions that all share the same root cause, right?
Yeah, the same pathology. It's all about reduced blood flow, usually from a coronary artery plaque rupture, and that leads to myocardial ischemia. The muscle is starved of oxygen.
And that spectrum is so important to understand because the management changes, drastically depending on where the patient falls.
It really does. The ACS landscape covers unstable angina, non-ST segment elevation myocardial infarction, what we all call NSTEMI, and of course, ST segment elevation myocardial infarction, the STEMI.
And we group the first two together, unstable angina and NSTEMI, because they look similar at first.
Right. They form this sort of heterogeneous group because they don't have that dramatic initial ST elevation that you see in a STEMI.
So in the ED, what is the clinical difference between unstable angina and NSTEMI? Because when they first come in, they can look identical.
The crucial separator, the thing that tells you what's really going on, is the blood marker, troponin.
Okay.
In unstable angina, the ischemia is bad enough to cause symptoms, sure, but it hasn't actually caused cell death. So the troponin levels stay normal.
But in an NSTEMI?
In an NSTEMI, we have evidence of actual myocardial cell deaths, and that's confirmed later when the elevated troponin levels come back from the lab. So when the patient first arrives, you're treating them as non-ST elevation ACS until that blood work is back.
Which is why that first troponin draw is so incredibly important. It really sets the course.
It determines the final diagnosis, yeah.
Okay. A patient is on the trolley. Classic story-crushing substernal chest pain. What is the absolute non-negotiable first 5 minutes diagnostic pathway? This has to be muscle memory.
The 12-lead ECG is king. It has to be done as soon as humanly possible. Ideally within the first couple of minutes of arrival.
And at the same time.
Simultaneously or right after, you have to get IV access and draw your initial bloods. That means samples for UNE urea and electrolytes glucose, a full blood count, and then critically, the serial troponin and maybe a BNP, a B-type natriuretic peptide. You need that baseline.
And while the ECG is printing, bloods are spinning, you've got maybe 60 seconds for a physical exam. What are the, say, 3 or 4 most critical, high-yield things an experienced clinician is looking for?
You are hunting for signs of immediate hemodynamic compromise or a critical complication. So first, listen to the heart. Are there new murmurs?
Looking for what, specifically?
You're listening for signs of papillary muscle rupture or maybe acute mitral regurgitation. A third heart sound, an S3 gallop, that's a huge red flag. It immediately makes you worry about uncontrolled heart failure or acute LVF.
Okay, heart sounds first. What's next?
Second, quickly check the lung fields for crackles, for diminished breath sounds. That points to pulmonary edema, another sign of LVS. Third, check peripheral pulses. Are they symmetric? Are they present? A difference suggests a possible aortic dissection, a massive danger you cannot afford to miss.
And the last one.
A quick check of the legs for any swelling or warmth. You're looking for signs of a DVT, a deep vein thrombosis, because that massively raises the possibility that this isn't an MI at all, but a PE mimic.
A really rapid-fire assessment. So once we have the initial labs and the ECG pointing towards ACS, especially in that NSTEMI group where the risk can be all over the place, quantifying that risk is key. Our source highlights the TMI score. How do we actually use that tool to make these high-stakes decisions?
The TMI risk score. It stands for thrombolysis. In myocardial infarction, it's a predictive tool. It's for stratification. It uses clinical variables, age, risk factors, prior history, aspirin use, ST depression, to predict mortality or a major adverse cardiac event within 14 days.
So it's not just an academic exercise.
No, not at all. The simple, vital takeaway is this. A higher score predicts a worse outcome. And that dictates everything. Does the patient stay in the ED, go to a cardiac observation unit, or do they need an urgent transfer for an early intervention? A high score means they need to see a cardiologist, probably in a cath lab, and fast.
Okay, let's pivot to the most time-critical presentation, the STEMI. This is the definition of time is muscle. The minute you see that ST elevation on the screen, what is the sequence of non-negotiable immediate actions?
The clock starts right then. First, oxygen, but, and this is important, only the patient is hypoxic. So in SpO2 below 94%, we've learned to avoid just blasting everyone with oxygen as it can actually worsen coronary vasoconstriction.
Okay, so oxygen if they need it, then secure IV access if you haven't already.
Correct. Then the dual antiplatelet regimen starts. You give aspirin, 300 milligrams orally, chewed, if it wasn't given pre-hospital. And that's followed immediately by a second antiplatelet agent, usually a P2Y12 inhibitor.
Our sources name a few: ticagrelor, clopidogrel, prasugrel. Let's focus on ticagrelor since it's often preferred. What's the loading dose and why is that combo with aspirin so effective?
The standard loading dose for ticagrelor is 180 milligrams orally. The combination is so powerful because aspirin works on one pathway of platelet aggregation, the cyclooxygenase pathway, and the P2Y12 inhibitors block a different crucial pathway that involves ADP.
So you're hitting the clot from two different sides.
Exactly. You're attacking the clot formation mechanism from two different angles to try and keep that coronary artery open until you can get to definitive reperfusion.
But with such powerful drugs, we have to be vigilant about the flip side. Before you give that second antiplatelet, what are the absolute contraindications for ticagrelor that a junior trainee has to check right now?
This is a critical safety check. You have to avoid ticagrelor if the patient has any history of intracranial hemorrhage, any signs of current active bleeding, like a major GI bleed, or known moderate to severe hepatic impairment.
What about other medications?
That's the other big one. If they're already on another anticoagulant, like a DOAC or warfarin, that's a massive red flag because the combination presents a catastrophic bleeding risk. You have to ask.
Okay, so beyond the initial drugs, the core management of STEMI is all about reperfusion.
No.
And this decision is timed to the minute. What are the two main pathways, and what's the critical time metric for choosing?
The two pathways are percutaneous coronary intervention, or PCI, which is an immediate transfer to the cath lab, and thrombolysis, which is giving clot-busting medication. PCI is always the priority.
So immediate transfer to the cath lab if they're within 12 hours of symptom onset.
Right. And there's an interesting exception. If a patient shows up more than 12 hours out, but they're in cardiogenic shock or have ongoing refractory chest pain, PCI is still the standard of care because they're fundamentally unstable.
Now, let's talk about the reality of working in an ED that might not have a 247 cath lab or faces long transfer times. When do you have to pivot to thrombolysis?
The rule is strict and it's universal. If PCI cannot be delivered, and by that we mean the balloon cannot be inflated in the artery within 90 minutes of diagnosis, You must offer thrombolysis.
So you assess the bleeding risk.
You assess the bleeding risk, and if it's acceptable, you administer a fibrinolytic agent like tenecteplase or ritaplase or alteplase. Every single minute of delay beyond that 90-minute window increases mortality.
To be eligible for these aggressive, time-critical strategies, the ECG has to meet very specific, non-subjective criteria. Can you lay out the clear requirements for activating those reperfusion protocols?
Sure. We're looking for specific degrees of ST elevation, greater than 1 millimeter in 2 or more contiguous limb leads, or ST elevation of 2 millimeters or more in 2 or more contiguous chest leads, V1 to V6.
And there's a third one, right, the LBBB.
The third crucial indicator is the presence of a new, or presumably new, left bundle branch block, an LBBB, but it has to be accompanied by a typical acute MI history. Those three findings are the immediate triggers.
The decision to give thrombolysis is terrifying. I mean, the risk of intracranial hemorrhage is real, so we need to be absolutely rigorous with the contraindications. Let's focus on the absolute red lines.
They have to be memorized
And
checked off meticulously. The most critical ones focus on intracranial risk. Any previous intracranial hemorrhage, any known cerebral tumor or metastasis, or a stroke of unknown origin.
Okay, so that's the head. What about active bleeding?
Then there's current bleeding risk.
Oh.
So inactive GI bleed, GU bleed, retroperitoneal, intraocular, anything within the last month. And we have to check blood pressure. Severe uncontrolled hypertension, specifically a systolic over 200 or a diastolic over 120, is an absolute no-go. The risk of causing a hemorrhagic stroke is just too high.
Any others?
Yes. Recent major surgery or trauma within the last 2 weeks, a low platelet count, so under 50, or the current use of any oral anticoagulant are all immediate stop signs.
That list really highlights how complex this is, even when it's life or death. What about the relative contraindications, the things that make you pause and call your consultant for a risk-benefit chat?
Right, the gray zone. This requires nuanced judgment. They include things like pregnancy, a stroke within the past year, major bleeding within the last 3 months, a history of any intracranial bleed, even if it was minor traumatic CPR or puncture of a non-compressible vessel like the subclavian vein during a procedure.
That's where you really have to weigh the risk of the drug against the certainty of death without reperfusion.
That's the conversation, exactly.
Before we wrap up ACS, let's zoom in on a bit of ECG nuance that can separate a junior trainee from an expert: the hyperacute changes. We usually wait for obvious ST elevation, but our source mentions a subtle finding that can signal ischemia minutes earlier.
Yeah, and this is where it gets really interesting. It requires genuine pattern recognition. Hyperacute changes are subtle and they're often missed. You can see them within minutes of a complete coronary occlusion.
And what is the specific detail?
The detail is an increase in the ventricular activation time. That's the interval from the start of the QRS complex to the very apex of the R wave. It might be prolonged to over 0.045 seconds.
And what does that mean physiologically? Why does that happen?
It reflects delayed conduction. The infarcting myocardium, the dying muscle, conducts electrical impulses slower than healthy tissue. So even while the ST segment hasn't fully risen to meet the criteria, that little delay in the R-wave peak is a signal that the electricity is struggling to get through.
So if you recognize this...
If you recognize this subtle sign, you can activate the cath lab protocol before the definitive ST criteria are even met. You're shaving off vital minutes, potentially preserving more muscle. It's an immediate sign that occlusion is happening right now.
Let's move on. The ED is just defined by patients who present with one thing but actually have another. We need to be wary of the great masqueraders that can present exactly like a massive MI but need completely different, sometimes opposite, management.
Yes.
Let's start with acute pericarditis, the positional chest pain masquerader.
Acute pericarditis. It's an inflammation of the pericardial sac, that fibrous layer around the heart. The classic clinical presentation, the thing that guides our differential, is a triad of 3 things.
Okay, what are they?
Pericardial pain, a pericardial friction rub that you can hear on auscultation, and the characteristic concordant ST elevation on the ECG.
Both ischemic pain and pericarditis pain are described as central and retrosternal. In a high-pressure exam, how do you pull out the key difference?
The pain characteristics are the absolute key. While MI pain is often crushing, pressure-like, relentless, pericardial pain is typically sharp, central, and critically, it's highly sensitive to movement and breathing.
So you have to ask the right question.
You have to ask, does the pain get worse when you take a deep breath? Does it change when you lean forward or lie flat? Pericarditis pain classically gets worse on deep inspiration, with exercise, or when lying supine, and it's often relieved by sitting up and leaning forward.
The source even mentioned something about swallowing.
Yeah, that a large pericardial effusion can cause dysphagia, difficulty swallowing, if that fluid sac expands enough to actually compress the esophagus.
Most viral or idiopathic pericarditis in, a young, healthy patient is benign. It's self-limiting. So when do we stop treating it in the ED and decide, okay, this patient needs to be admitted? What are the high-risk features?
We have to admit any patient with high-risk features suggesting a more complicated or secondary cause. That list includes a significant fever, so pyrexia above 38 Celsius, an increased white cell count, any evidence of a large pericardial effusion, or signs of tamponade.
What else?
Also, acute trauma, any underlying immunosuppression, or if they're on oral anticoagulation, which just complicates everything. And crucially, you also admit them if they fail to respond to a standard course of NSAIDs after a few days.
And the most immediate life-threatening complication of pericarditis is cardiac tamponade. This requires immediate, decisive action.
Tamponade is a true hemodynamic emergency. It happens when the pressure inside that pericardial sac equals or exceeds the filling pressure of the right side of the heart. The heart just can't fill properly.
So you'll see signs of shock.
You'll see shock. And the classic features are an elevated JVP, hypotension, and muffled heart sounds. This demands immediate senior help and a bedside echo, which will show the right heart collapsing during diastole.
And the intervention?
The intervention is immediate pericardiocentesis, draining the fluid under ultrasound guidance, followed by definitive drainage. It's also worth remembering that the ECG sign of a large effusion is often a decreased QRS amplitude in all the leads. The fluid acts like an electrical buffer.
Okay, now on to the really catastrophic one, aortic dissection. Why is it so critical to have a high index of suspicion here beyond the obvious risk?
Because treating a dissection with the thrombolytics, or antiplatelets you'd use for a STEMI, turns a critical situation into a guaranteed catastrophe. You will kill the patient.
So how does it present?
It presents with excruciating, abrupt onset pain. And crucially, it's often described as sharp, tearing, or ripping, and it is maximal at its onset.
That's different from an MI.
Very different. MI pain typically builds over minutes. Dissection pain is maximal from second one. And the pain often migrates or recurs as the dissection flap extends down the aorta. Syncope happens in about 10% of cases too.
And it can mimic other things too, right? Like stroke?
Precisely. If we connect this to the bigger picture, that false lumen created by the tear can compromise any major artery branching off the aorta. So yeah, involvement of the supraortic vessels can cause an acute stroke if the celiac or mesenteric arteries get involved. You've got bowel ischemia, renal arteries, you get acute kidney injury.
And we classify them into Stanford type A and B?
Right. Stanford type A involves the ascending aorta and needs immediate cardiac surgery. Type B involves only the descending aorta.
So we suspect dissection based on the history, abrupt maximal pain, maybe a pulse deficit. What is the single immediate management priority that overrides everything else, even a definitive diagnosis?
Control the blood pressure, immediately and precisely. The whole goal is to reduce the shear stress on that aortic wall, which is what's propagating the tear. But you have to do it without causing severe hypoperfusion to the brain or kidneys.
So what's the target?
The critical target, cited in our sources, is to reduce the systolic BP by no more than 25% in the first hour. And you have to use IV agents for this. Labetalol or sodium nitroprusside are often used because they're titratable, rapid onset, and short-acting. It lets you carefully walk that very fine line of BP control.
Okay, we've covered structural damage and ischemia. Let's move to the electrical and vascular emergencies that cause that sudden, profound collapse. Starting with tachyarrhythmias, the electrical crisis. We've got an unstable patient, heart rate of 180. How do we quickly categorize this rhythm and manage them?
The first step is always the ECG and then categorizing by the QRS width, narrow complex versus broad complex. But if the patient is unstable, hypotensive, altered mental status, signs of shock, the answer is immediate synchronized cardioversion. It almost doesn't matter what the rhythm is. You shock them.
Okay, but assuming they're stable for a moment, let's look at the narrow complex regular tachycardias.
If it's regular and narrow, and it's clearly not just sinus tachycardia, we're mainly thinking about paroxysmal SVT or PSVT and atrial flutter.
Is there a giveaway for atrial flutter?
There is. If you see a ventricular rate that is precisely 150 beats per minute, it is highly, highly likely to be atrial flutter with a 2-to-1 block. PSVT, on the other hand, typically responds extremely well to vagal maneuvers or to a dose of adenosine, which transiently blocks the AV node and terminates that reentry circuit.
And what about the most common sustained arrhythmia we see, atrial fibrillation, or AF? What's its primary systemic threat?
AF is just chaotic electrical activity in the atria. It leads to poor ventricular filling and often a rapid, irregular pulse. While controlling the rate is our immediate ED priority for stability, the long-term threat is its massive association with stroke.
Because of clot formation.
Exactly. The chaotic rhythm causes blood stasis in the left atrial appendage, which leads to clot formation and then potential cerebral emboli. For broad, complex tachyarrhythmias, we're generally worried about ventricular tachycardia, VT, and the highly unstable, often drug-induced, torsades de pointe. VT is a lethal rhythm until you prove otherwise.
On the other side of the coin, we have the bradyarrhythmias. When does temporary pacing become necessary, and what's that fascinating, almost forgotten bedside measure we can use to bridge the gap before pacing is set up?
Pacing, either transcutaneous or transvenous, is indicated for extreme bradyarrhythmias that are causing hemodynamic instability, like a symptomatic complete heart block.
What about in a systole?
In a systole, its value is typically unproven. The exception is if you can still see discernible P waves, which suggests the problem is a failure of conduction, not a complete lack of atrial activity.
Okay, and the bridge measure, external cardiac percussion.
It sounds archaic, doesn't it? But it's a valid, desperate measure to buy time when electrical pacing is delayed. You use a clenched fist, not too aggressively, and you strike firmly over the heart's position at a rate of about 100 per minute.
What's the goal there?
The physiological goal is for the mechanical energy of each blow to trigger a QRS complex. You're trying to generate a temporary, even if this poor cardiac output, until the pacing leads are on and working. It's a last resort, but knowing it exists shows a deep understanding of basic cardiac physiology.
Next up, pulmonary embolism, or PE. It's fundamentally a massive cardiac vascular emergency that causes sudden obstructive shock. What are the key presentation clues, especially in an unstable patient?
The hallmark symptom is dyspnea, shortness of breath. It is the most common complaint. But you have to maintain a high index of suspicion for PE in any patient with unexplained hypoxia or breathlessness.
And for a massive TE?
Signs of a truly massive PE are cardiovascular collapse, so syncope with cyanosis, or the patient presenting in full cardiac arrest. Pleuritic chest pain is common, but its absence doesn't rule PE out. Many massive PEs present purely with hemodynamic failure.
For the stable patient where it's still a possibility, how do we use clinical scoring and basic labs to rapidly rule it out in the ED?
We rely on the Wells score for clinical probability. The Wells score assigns points for things like clinical signs of a DVT, prior history, recent surgery, and whether an alternative diagnosis is less likely.
And how do we interpret the score?
If the score is 1 point or less, the probability is unlikely. And if it's unlikely and the D-dimer blood test is normal, then a DVT or PE is effectively ruled out.
Sounds like a perfect test. But what's the big pitfall with the D-dimer?
The pitfall is that the D-dimer is useless if the patient has any concurrent inflammatory process, trauma, recent surgery, cancer, anything that increases generalized clotting and fibrin breakdown. The D-dimer will be high, but it's nonspecific. Its only real utility is in ruling out PE in a low-risk patient.
So if the Wells score is high or the D-dimer is elevated?
Then the patient needs definitive imaging, usually a CT pulmonary angiogram, a CTPA, or maybe a VQ scan.
What if the patient is unstable? In frank shock from a massive PE, the standard diagnostic pathway is just too slow.
Yeah, if the patient is in shock unstable, hypotensive, you skip the imaging and you start immediate treatment to break down the clot. Secure the airway, high flow oxygen, get robust IV access, and administer thrombolysis immediately, something like alteplase.
Assuming no contraindications.
Right, assuming the contraindications we talked about for STEMI are absent. The rationale is that their circulation just can't sustain itself long enough for a transfer or surgery. If thrombolysis is contraindicated, or if it fails, you have to urgently liaise with specialists to consider surgical embolectomy or catheter-directed thrombolysis.
For the stable patients who are confirmed to have a PE, what are the modern treatment options? Let's focus on the specific anticoagulants from our source.
Anticoagulation is the cornerstone of long-term management. We mainly use direct oral anticoagulants, the DOACs, as first-line therapy now.
For example,
For example, rivaroxaban, which starts with a 15 milligram oral dose twice a day for 21 days, then drops to a 20 milligram daily maintenance dose. Or apixaban, which has a shorter loading period, 10 milligrams twice a day for 7 days, then 5 milligrams twice a day.
What about injectable options?
For injectable options, we often use a low molecular weight heparin like enoxaparin, which is dosed at 1 milligram per kilogram subcutaneously twice a day, with a max dose of 100 milligrams per injection.
There is a specific clinical situation where the older drug, unfractionated heparin, UFH, is still the anticoagulant of choice. Why is UFH still preferred in these high-risk scenarios?
UFH is the anticoagulant of choice in two specific critical situations: patients with severe renal impairment and patients at a very high risk of a major bleed.
And the reason is physiological.
Yes. UFH has an extremely short half-life, and it's rapidly reversible with protamine sulfate. If you give a DOAC to someone with severe renal failure, the drug will accumulate to dangerous levels. If a patient on UFH has a life-threatening bleed, you can stop the infusion and reverse the effect much, much faster than with the newer agents. It offers a crucial safety margin.
Okay, the heart rarely fails in isolation. We have to be experts at recognizing systemic issues that present with cardiac collapse, and the main one is sepsis. When a patient just looks acutely unwell, we need a rapid, structured approach, a quick sepsis screen.
Absolutely. The goal is to identify patients who are likely to deteriorate before they actually crash. We use a score that's similar to QSOFA, the Quick Sequential Organ Failure Assessment, to rapidly flag patients with an increased mortality risk.
How does that work?
You give 1 point for each of 3 signs: a respiratory rate of 22 or higher, a systolic blood pressure of 100 or lower, or any sign of an altered mental state. A score of 2 or 3 indicates a significantly increased mortality risk, and it demands immediate aggressive intervention.
And what's the simple lab value we rely on heavily for initial identification and for tracking our treatment response?
That's the blood lactate level. It's a critical marker of tissue hypoperfusion. An elevated lactate is extremely helpful in the initial identification of sepsis in the ED.
Also, it's high.
If the blood lactate is 2 millimoles per liter or higher, which suggests poor perfusion, you have to treat them and then repeat that level within 2 hours to see if your resuscitation is working. If the lactate isn't dropping, you need to escalate care. You're probably going to need to start vasopressors.
To ensure that rapid, coordinated action, we rely on the Sepsis 6 bundle. It's non-negotiable and has to be delivered within the first hour. This is the bare minimum to prevent a systemic collapse. Let's run through those 6 critical components.
Okay, the Sepsis 6 bundle. It's a template for structured resuscitation. Number 1, provide high-flow oxygen to optimize saturation.
Number 2, take blood cultures before antibiotics so you can identify the bug later.
3, administer fourth fluids. Aggressive resuscitation to restore intravascular volume and address that distributive shock from massive vasodilation.
4, administer fourth antibiotics. Broad spectrum within the hour to stop the infection before organ damage is irreversible.
5, measure blood lactate and repeat it if it's elevated. This tracks the success of your perfusion management.
And number 6, monitor urine output hourly. You need a catheter for this. It's the clearest real-time measure of renal and overall organ perfusion.
Exactly. And while you're working through the Sepsis 6, you have to think about sources of infection beyond the usual suspects.
Right. Our source material reminds us of these less common but high-risk infections that can present as profound septic shock, and they can mimic cardiac failure.
Yeah, we can't just limit our search to chest and urine infections. You have to broaden the differential. Think about endocarditis, meningitis, a GI perforation, osteomyelitis, and line sepsis if the patient has any kind of indwelling central line.
And septic shock is defined by...
It's defined by the failure of adequate organ perfusion. Clinically, you recognize it by hypotension, a systolic BP below 90, despite your initial fluid resuscitation.
And speaking of fluid, we have to put huge caveat on aggressive fluid administration, especially in a patient with systemic collapse. How do we differentiate and manage the fluid needs in septic versus cardiogenic shock?
This is so important.
Yeah.
Septic shock typically needs aggressive fluid resuscitation. We're talking crystalloids like 0.9% saline, titrated in boluses up to 20 or 30 mils per kilo initially.
Yeah.
You're trying to fill up that massive dilated vascular space. However, you have to be extremely cautious if you suspect the shock has a cardiogenic cause, like a massive MI or acute severe heart failure, or if you suspect hemorrhage, like a ruptured AAA. If you overload a failing heart with fluid, you can precipitate acute fatal pulmonary edema.
So what's the principle?
The principle is check for fluid responsiveness, and if the heart is failing, you transition quickly to vasopressors and inotropes, which you should have been getting ready simultaneously.
Okay, let's move to the apex of emergency medicine, cardiac arrest management. The timing of adrenaline is absolutely critical, and it depends on the rhythm.
Adrenaline is the mainstay drug after you've ensured adequate oxygenation and ventilation. For ventricular fibrillation, VF, or pulseless ventricular tachycardia, VT, the shockable rhythms adrenaline is given after 3 attempts at defibrillation have failed.
But for non-shockable rhythms,
For asystole, the flatline or pulseless electrical activity, PEA, the non-shockable rhythms, you give adrenaline as soon as possible, often at the same time as the first cycle of CPR. You do not delay drugs in non-shockable rhythms.
what exactly is PE, and why is knowing the potential underlying causes so critical for a successful resuscitation?
PEA is cardiac arrest, where the ECG shows an organized electrical trace. It looks like the heart is still generating a signal, but there is absolutely no palpable pulse, no mechanical output. It's a fundamental failure of the mechanical pump.
And it's often caused by reversible things.
Exactly. It's often caused by massive obstruction or profound metabolic derangement. We think of the common reversible causes, the 4 H's and 4 T's.
Let's quickly review a few of the critical ones that relate to our cardiac theme.
Think about the T's: tamponade, tension pneumothorax, thrombosis, either coronary or pulmonary. Our source specifically cites a massive MI as a cause of PEA. If the cardiac muscle is suddenly 90% ischemic, it just can't generate force, and you get PEA despite the electrical activity. And the H's include things like hypovolemia and hypoxia. Successful PEA management depends entirely on rapidly diagnosing and reversing that underlying cause.
Let's say we're successful. We achieve return of spontaneous circulation, ROSC. The patient immediately transitions into post-arrest care, which is heavily focused on protecting the brain. What are the 2 main priorities for hemodynamics and neurological status in that post-ROSC phase?
First, you have to optimize cerebral perfusion. It's a major determinant of neurological outcome. Post-arrest, the brain's ability to self-regulate as blood flow is shot. So we have to maintain arterial pressures that are normal for that individual patient. We often target a MAP around 65 to 70, but we have to avoid both hypotension, which causes hypoperfusion, and excessive hypertension, which can worsen cerebral edema.
And the second priority?
Second, we have to treat seizures aggressively. Seizures aggravate brain injury by massively increasing intracranial pressure and metabolic demands. They have to be controlled immediately with appropriate anticonvulsants like IV lorazepam or diazepam, while you're paying meticulous attention to their oxygenation and ventilation.
Finally, let's touch on a crucial practical skill for a junior trainee in the resusp: getting central vascular access under pressure. We need large bore access, and we need it fast. What's the technique of choice, and which veins do we prefer?
The Seldinger technique is the method of choice for central line insertion. It relies on inserting a guide wire through a fine needle first, then you thread a dilator and the final cannula over the wire.
And that's safer.
It reduces the risk of major complications compared to the older methods, because you're only inserting a fine needle initially to establish the access. It minimizes the risk of vessel or lung trauma, specifically in pneumothorax.
We often debate between the major central veins. Why is the internal jugular, the IJ, generally preferred over the subclavian?
The IJ is usually preferable to the subclavian because of the significantly lower risk of pneumothorax, especially if you're doing it under ultrasound guidance.
And right side versus left.
Accessing the right side of the neck is generally preferred. The path to the vena cava is straighter, and using the right side decreases the risk of inadvertently damaging the thoracic duct, which drains into the left subclavian vein.
What about the femoral vein?
The femoral vein is still a really useful and safer alternative for temporary access in scenarios where patients have severe trauma, burns, or poor access from IV drug use, because it avoids all the chest and neck structures entirely.
So we have spent time dissecting the rapid, high-stakes decisions required in that first hour of managing acute cardiac emergencies.
Yeah, from the subtle ECG changes that signal a hyperacute MI to the really complex hemodynamic management of shock from a massive PE or sepsis. The key connecting thread for any clinician is this: vigilance. You must always be reassessing, always challenging your initial diagnosis, especially when the symptoms don't perfectly align with the textbook.
This deep dive really reinforced for me that while cardiac emergencies can feel like pure chaos, there is a standardized, time-critical process. Whether you're starting dual antiplatelets for a STEMI or titrating 4-vilabitol for a suspected aortic dissection.
It's about merging deep knowledge with Immediate, decisive, and structured action. Before we wrap up, let's circle back to a fundamental principle we mentioned right at the start. It's a rule that sometimes gets ignored under the pressure of diagnostic uncertainty, especially with chest or abdominal pain. It's the analgesia rule.
And the critical reminder is never delay appropriate analgesia for a patient in pain.
Precisely. The outdated traditional concern that giving pain relief might mask critical signs or symptoms, like the rigidity of an acute abdomen or the changing nature of chest pain, is explicitly condemned in modern emergency protocols. It's inhumane, and frankly, it's incorrect.
It's just bad medicine.
It is. Treating pain isn't just compassionate care. It's good clinical practice. Relieving pain often calms the patient down and allows them to give you a clearer, more detailed history. They can cooperate more fully with your exam, which ultimately aids your diagnosis rather than hindering it.
That is such a crucial point of patient advocacy and clinical efficiency that can get lost in the rush. Okay, now for the final provocative thought to carry forward from this. We focused heavily on the hemodynamically unstable catastrophes. But think about the incredible difficulty in distinguishing between common, benign causes of chest pain like costochondritis or simple anxiety, and a potentially fatal aortic dissection in a patient who is currently hemodynamically stable. Given the gravity of that diagnosis, what small, seemingly routine piece of information like finding an old ECG for immediate comparison or meticulously measuring bilateral pulses and blood pressures for even a slight difference, what becomes the critical data point?
Yeah.
That single subtle piece of information is the one that separates simple observation and discharge from immediate, life-saving intervention. Continue to drill that differential diagnosis because vigilance at that level will save a life one day.